All right, welcome officially everyone to our April Good Beginnings in Power Hour. And for those of you who may be new, this is something we host once a month. We're playing with the times, but we think the lunchtime is going to end up working out. And this is where we bring in either our own speakers or speakers from the community who are here to educate and empower you about something related to either being a parent or being a parent of someone with special needs, or something related to pediatric healthcare in general, or any of the above. So this month, we are so excited to welcome Dr. Kelly Pham, who is a recent relocation back to the area. She returned back from the Pacific Northwest, where she's been at Seattle Children's Hospital for over 10 years, bringing all of her knowledge and expertise and her drive to want to improve services in the Northern Virginia area. Today, she's going to be talking to us about toe walking and how she feels why kids do it and how to manage it. And at the end, we have an exciting announcement about some new opportunities for toe walking management in the area. This is being recorded, so please make sure to leave your video and audio off. And at the end, there'll be time for questions, and I'll facilitate that for you. So you can type questions in the chat all along the way, and we'll have Q&A at the end. So Kelly, take it away.
All right. Thank you so much for the introduction, Amy, and for asking me to do this talk. Toe walking is something that I see quite a bit of, and I manage quite a bit, and I really enjoy managing and teaching about. So I wanted to just introduce myself a little bit more first. As Amy mentioned, I'm a pediatric rehab doctor, so pediatric physiatrist, and I describe myself as the doctor of function. So my goal for patients is for them to be as high functioning as possible, or to be as comfortable, or to provide support for caregivers so that they're able to manage their children and care for their children as easily as possible. So that's what I do. I work with a variety of different children and also young adults as well. My primary population, I would say, are children who have cerebral palsy, but I also work with a lot of kids who toe walk, who have brain injury, spinal cord injury, spina bifida, concussion, torticollis. So the range of diagnoses is quite big. And so I'm kind of a jack of all trades as it pertains to function. Like Amy mentioned, I started my medical career in this area at Georgetown for medical school, stayed nearby for my residency program at Johns Hopkins, and then went out to the Pacific Northwest for my fellowship at Seattle Children's Hospital, and ended up staying on as faculty at Seattle Children's, but also at the University of Washington, where I was an assistant professor. So I've done lots of publishing and research and quality improvement in the area of my practice over the last 8 years. I am passionate about what I do, and I feel very lucky to be passionate about what I do. I know lots of physicians, and after 12 to 14 years of education, a lot of people get into medicine and find, gosh, I don't really enjoy this. I am not one of those people, and I feel very lucky that I love what I do, and I am passionate about what I do in caring for children and their families with disabilities. So I'm a teacher. Like I said, I was teaching at the University of Washington and at Seattle Children's Hospital, teaching residents, fellows, and medical students. But I've also done a lot of teaching in the community for patients and families, as well as for community providers. So it's something I really enjoy doing. I actually, just an exciting bit of news, I'm working with a group through the American Academy of Cerebral Palsy and Developmental Medicine, and we just got accepted to do a mini symposium at the national conference in September in, I believe it's in Las Vegas, on advocacy efforts for children with disabilities. So it's something also that I'm passionate about. I am a lifelong learner, and I think you have to be in the field of medicine because the field of medicine is constantly changing. So I love learning, and I love being able to take that information that I've learned and utilize it in caring for children and also teaching the providers who I collaborate with. I am a collaborator. I work very, very closely with therapists in the community. Historically, I've had a really close-knit team in my tone management clinic that I've worked very directly with in the care of patients who have high muscle tone. And I think that it's so important for patients and for families, for us as medical providers, to collaborate. I can't tell you how many times I've seen the patient and family be sort of the pickle in the middle, and hearing different things from different providers and us not doing a great job communicating. So I think that that's really important. I live in Arlington, so I live in Northern Virginia with my husband, who's an ophthalmologist, and my son, Emil, who is 3, and our dog, Lula, who I think has struggled the most with the move across the country, but she's getting better. My other passions outside of medicine are fitness. I'm a bit of a fitness fanatic, which is good because I also like to bake. So those kind of balance each other out. I'm pretty passionate about climate change. I really enjoy nature, and I sort of miss the mountains of the West Coast. And I enjoy travel, and hopefully we'll be able to get back to that someday soon. So that's a little bit about me. Now, a little bit about my practice. So I, as you know, went from working at Seattle Children's Hospital, which is a big pediatric hospital that served Washington, Wyoming, Alaska, Montana, Idaho, and part of Northern Oregon. So big hospital, huge catchment area. So I went from that sort of setting to a very different setting now with Reach Pediatric Rehab. And my goal with this very small and intimate practice is to be able to really provide that evidence-based care. So care that is based on the newest research, which is really important to me. I want to be able to provide thorough evaluations, and that takes time. Time for reviewing records, time for gathering information from patients, time for a very complete examination and education of patients and families. And that leads to my next goal, which is education. I love educating. Like I said, I am an educator, I'm a teacher, I love to learn, I love to teach, and I want to be able to do that through this practice, which again also takes time. My goal also, in addition to teaching patients and families in the clinic, is to teach the community and engage the community through events such as this. Collaboration is another huge goal of mine because I think that we provide better care when we collaborate. My office is easily accessible. So compared to a big hospital where you have to stop at 5 different stations before you get to see the doctor, in my office, you just walk in the front door and then into my office, which is really quite easy and I think a little less intimidating for patients and families. And my other goal is on-time appointments. I can appreciate as a parent, as someone who consumes healthcare, but also as a provider, how important that is for people. People are busy, they take off from work to come to these appointments. So being on time is very important to me. So let's move on then. And I'm sorry, one last thing. So I'm located in Vienna, Virginia, right across from Tyson's Corner. You'll have my website here. I'm on social media, and I now have a YouTube channel where I've started doing some short videos, educational videos on different topics like cerebral palsy, like toe walking. And I'm going to be doing some on AFOs coming up soon. So keep an eye out for those. Subscribe, follow me on social media. You'll find lots of new information coming there. And Amy, if you don't mind, I just saw something pop up in the chat. If you don't mind following that, and please interrupt me if something comes up. I'm happy to answer questions or to chat about things as we move along. All right, so my objectives for today are to explore the causes of toe walking, explain the basic workup for toe walking, and review management options. And we're going to do that through a case. I really like doing cases because I think it sort of brings things back to what actually is happening, is seeing a child who comes into clinic. So this is Cecilia. So she toe walks into clinic, and the first thing that I do as a rehab provider is I gather a lot of history, so a lot of information. So Cecilia is 6 years old, and she was referred by her PT to see me for an evaluation for her toe walking. Now, she was born a little bit early at 36 weeks. but no complications of the pregnancy. Her delivery at 36 weeks was due to intrauterine growth restriction. So she was small, she wasn't growing as she should have been, and so she was delivered early. She went home from the hospital on day of life 2 with her mother and didn't have any complications with her hospital stay. She's otherwise very healthy. She doesn't have any other medical problems, has never had any surgeries. Developmentally, she has no delays that the family are aware of. So she started sitting at about 6 months, walking at about 12 months. Her first words were around 12 or 13 months. She's right hand dominant, and she can color and draw, and she can also write her name. So these are all important things that I want to know when I first meet a child who comes in for toe walking. Now, the family history, oftentimes we don't think about this as being important, especially when it comes to something like toe walking, but it is. And so for Cecilia, it turns out that her father walked on his toes as a child, but sort of outgrew that. Her father also has very high arches, which is important for us to think about. And we'll talk about that more when we get to the cause of toe walking. Now, when we talk about the history of present illness, this is the information all about the toe walking, all about why Cecilia came in for her visit today. So she has been walking on her toes ever since she started walking. This is not new. The pediatrician said that she would grow out of it. She walks about 80% of the time on her toes, but she can get her feet flat onto the ground. She complains of pain at the end of the day. She sometimes trips and falls when she's walking on her toes. And with further questioning, it turns out she has some sensory preferences for softer foods, not liking people to touch her feet. She has no accidents with her bowels or her bladder. And she has seen physical therapy for just one visit for her initial evaluation and was referred here today for evaluation with me. So that's sort of a brief introduction to Cecilia, and we'll continue to follow her through as we learn about toe walking. Now, we're going to start by talking about the etiology, basically the cause. So what causes kids to walk on their toes? And I like to think of this from top to bottom. So in this picture, you'll see the brain, and the brain is sort of where lots of information is modulated. And the brain sends information down to the spinal cord. The spinal cord sends information through the nerves out into your muscles and kind of tells your muscles what to do. And so when we think about the cause of toe walking, the cause can be anywhere along that pathway. So some children who have cerebral palsy, for example, this is an injury to the brain as it's developing. It's not a progressive injury. It's just an unchanging injury or a static injury to the brain. And that can cause high muscle tone and cause kids to walk on their toes. Any other sort of injury to the brain can also cause kids to walk on their toes. And there are lots of different things that can cause injury to the brain, including things like trauma, how the brain is formed as the baby is developing when they're in utero or in the mama's belly. And so there are lots of things that can happen to the brain that can result in high muscle tone that can result in toe walking. When we move down to the spinal cord, any sort of injury to the spinal cord similarly can cause high muscle tone in the muscles in the legs and or the arms and cause a child to walk on their toes. So we also have to think about the spinal cord. Things that can happen in the spinal cord include malformations of the spinal cord, tethering of the spinal cord, meaning that the spinal cord is sort of attached and not kind of as mobile as it typically is, as well as spinal cord injury. So those are some of the things that we think about as happening in the spinal cord that can cause a child to walk on their toes. After the spinal cord, we have that peripheral nerve. Peripheral just means it's sort of on the outside. meaning further away from the center of your body. And so that nerve takes information from the spinal cord to the muscle. And there are certain disorders called peripheral neuropathies. Peripheral just meaning it's sort of outside of the center of the body, and neuropathy meaning injury to the nerve. And you can see in this picture, this is the nerve, and this is the nerve as it sort of attaches to the muscle and gives information to the muscle. Now, there are some genetic disorders and disorders that are passed from parents to child that can cause neuropathy or injury to these nerves. And so that's one of the reasons why I ask about high arches, because if there's injury to the nerve, some of the muscles can be weak, some of the muscles can be strong, and that imbalance of muscles can cause high arches. That imbalance of muscles can cause kids to walk on their toes. It can also result in differences in sensation. So this will be important when we get to examining a child who is walking on their toes. Okay, so we've gotten through the brain and the spinal cord and the peripheral nerve, and now moving on to the muscle. Now, if there's damage to the muscle, usually it's due to some sort of genetic disorder. The most common things that we see are children who have Duchenne muscular dystrophy or Becker muscular dystrophy. So there's a problem with the muscle. And so these kids, what happens is they have weakness of certain muscles, usually the muscles that are in the hips and the quadriceps, or the thigh muscles in particular. And so they walk on their toes because it stabilizes their knees. And so another reason, very different from other reasons why kids walk on their toes, but another reason for a child to walk on their toes. So those are the causes that I think about when I think of this sort of top to bottom nervous system involvement in toe walking. Now, there are an increasing number of kids who we're seeing who have sensory preferences, and we're seeing a lot more kids who have these sensory preferences that cause them to walk on their toes. And some people say that some kids are maybe avoiding contact with the ground, and so they walk up on their toes. Or some kids, they really like that pressure of putting their entire body weight through their toes. So, and that's why we call that sensory preferences or sensory differences. And that's something that we work pretty closely with occupational therapists to sort of delve into further. Now, if we go through all of our history, all of our examination, and we can't find a cause, we call this idiopathic toe walking. And idiopathic really just means we don't know why, but we've ruled out all of the other causes of toe walking. And so we call it idiopathic. This is also something that we commonly see, and we manage these differently. And if people have questions as we go along, if you want to put them in the chat, Amy, if you can follow that and shout out questions, or we can certainly save questions for the end.
So far, we're good. Just letting you know.
Okay.
I think you're doing a really good job of explaining it. That's why there's no questions.
Okay, great. So back to Cecilia. So Cecilia came into your clinic, our clinic, and we went through her history. Now we're going to do an exam. And so we do a full neurologic exam from head to toe. We're looking at strength. We're looking at reflexes, we're looking at muscle tone, we're looking at sensation, and all of these portions of the exam give me an idea as to whether or not the brain might be involved, the spinal cord might be involved, the peripheral nerves might be involved, or the muscle might be involved. And beyond the neurological exam, we also do a musculoskeletal exam. And so this involves range of motion or checking flexibility. And you can see that in this picture. We're looking at flexibility of the calf muscle with the knee straight. And we'll talk a little bit about that in the coming slides. We also do a spine evaluation, sort of looking at whether or not the spine has any sort of curve to it. We're also looking for any signs of spina bifida, any changes on the outside of the spine, which can be an indicator of something going on internally. And so for Cecilia, we found that her neurological examination was completely normal. With her flexibility exam, her range of motion exam, we found that her ankle dorsiflexion, which I'm going to pull out my foot here because I love using my foot. So this is the foot at about 90 degrees. And this movement is dorsiflexion, so pulling the foot up. And normal is to get about 20 degrees of dorsiflexion. And this is plantar flexion, or pointing the foot down. So for Cecilia, with her knee bent, we were able to get her to just that 90 degrees of dorsiflexion. So she wasn't able to get all the way up to 20. With her knee extended, or her knee straight, she actually had her foot pointing down. So she had minus 10 degrees. So it was 10 degrees into plantar flexion. So with her knee straight, was not really able to even get to that 90 degree mark. And that 90 degree mark is really important because that's what you need when you're walking to be able to clear your foot, so that you don't drag your foot when you're walking. So the calf muscles are really important to understand. And the reason why I bring this up is because that what the ankle looks like with the knee bent and what the ankle looks like with the knee extended is really based on these muscles. And so if you think about the foot again in the context of these muscles, you'll see the deep muscle is called the soleus muscle. And it originates, or it starts up here below the knee, and then it inserts, or it ends right here at the foot bone, the calcaneus, in the Achilles tendon. And then more superficial to that are the gastrocnemius muscles. And those muscles start above the knee and then again insert on the Achilles tendon and the calcaneus, which is this bone in the foot. And so when we have the knee bent, we've made the gastrocnemius short. And so we're not really looking at the gastrocnemius when the knee is bent. We're looking at the soleus muscle because we've put the gastrocnemius on slack by bending the knee. When we extend the knee, we're looking at both muscles. We're looking at the soleus and the gastrocnemius muscles together. We already sort of know what's going on with the soleus, so it really gives us more information about the gastrocnemius. And oftentimes the gastrocnemius muscle ends up being the tighter muscle. And the reason this is important is because sometimes when you're walking, in certain phases of your gait, your knee is bent, in certain phases of your gait, your knee is straight. And so having that range of motion in different settings is really important to know about. Now, okay, so we've done our exam. The next thing we need to think about is the workup. So how do we figure out what the cause is for a child's toe walking? And the workup really depends on what we found in the history and what we found on physical exam. So if I'm concerned about something going on either in the brain or in the spine, I would recommend an MRI. And that gives us a really detailed image of the brain and the spinal cord. Oftentimes we do both because oftentimes the reason is because we're seeing some sort of neurologic difference to suggest that there may be something going on in the brain or the spinal cord. If we're worried about something going on in those nerves, those peripheral nerves, we might recommend something called a nerve conduction study, EMG, which stands for electromyography. And that gives us information about the health of the nerves and the health of the muscles. It's not a very easy test to tolerate. It's pretty uncomfortable. In certain ages, we do it with sedation, so when kids are asleep, but that can give us information about the health of the nerves. And then sometimes we recommend a blood draw to look at certain muscle enzymes. The one in particular that we often look at is the CK, or creatine kinase, for evaluating for one of those muscle disorders if we think that there's something going on with the muscle. So that's part of our workup. So Cecilia, if you'll remember, She was born prematurely, but really didn't have any complications otherwise of the pregnancy or delivery. She had a normal neurologic examination, but had some tightness in her ankles and maybe some sensory preferences. So for her, her workup would include an evaluation with occupational therapy for sensory differences to see, A, is there something we can do about that to kind of help her with those sensory differences to allow her to walk with a more typical gait pattern. Now, moving on to management of toe walking. This really depends on the cause, right? So if we find that there's something going on in the brain or something going on in the spinal cord, our management will be very different from if this is idiopathic. And so we always want to manage the underlying cause if at all possible. And so for kids who have high muscle tone, the management may include managing that high muscle tone with different interventions. For a kid who's found to have a muscle disorder or muscular dystrophy, we may end up going the route of steroid treatment. So they're very different types of treatments. If the spinal cord is tethered, we recommend a surgery to detether, untether the cord, the spinal cord. So it really depends on what's causing it as to what our management is. If it's idiopathic, we just sort of go down the route of treatment. But if it's not idiopathic, we want to manage the cause when at all possible.
Carly, can I interrupt for a second? And just, can you give some numbers of what you see, the proportions of toe walking related to these more medical issues where the workup is really where you're doing versus what you've been seeing as idiopathic, just in case there are some parents on the call who are like, wait, what?
Yes, it's a great question. So, I can't tell you how many times I see a child who comes in with toe walking and I find that they have some mild spasticity, which is a type of high muscle tone that really is mild enough that it hasn't been identified. And so we end up doing an MRI of the brain and spine and come to find out that maybe they have cerebral palsy. That probably is the more common diagnosis that I see from a child who comes to me with toe walking. So I would say of any of the medical causes, that's probably the most common that I see. Most kids who we end up seeing have idiopathic toe walking or toe walking related to sensory differences. And some people would say that, well, sensory differences, that is idiopathic, but I think we don't really know yet. There's not enough research on these children who have sensory preferences to say that this is idiopathic or it's caused by something. I would say the majority of the patients fit in that sort of idiopathic or sensory preference area, but I've seen a fair number of patients, maybe like 20-25%, who come in and we're surprised to find that they have high muscle tone. And we end up going down that route of imaging.
Great, thanks for that.
Yeah, you're welcome. Sorry, my screen just switched on me. Hold on. I'm gonna stop sharing and I'm gonna try sharing again. Sorry about that. There we go. Excellent question. So can you see my screen now? Does it look good?
Yep, it's all good.
Okay, thank you. Okay, so when we think about management, once we've sort of managed that underlying cause, we manage these kids in a number of ways with a number of different goals. So one of the things that we manage is contracture. Contracture is just a shortening of the muscle or tendon that happens over time from walking up on your toes. When you walk up on your toes, it puts this muscle and tendon, the gastrocnemius and soleus muscles and the Achilles tendon into a short position. And so when it's in that short position for a long time, sometimes it can get tight and contracted. And so we like to manage that contracture because you can't get your heel on the ground if you don't have the flexibility to do that. And so the most conservative way to do that is through a stretching or elongation program. And so here in this picture, you'll see this is a perfect stretch to get those gastrocnemius and soleus muscles. And so that can be a very important part of managing contracture, especially if the contracture is mild. Next thing we sometimes recommend are nighttime ankle foot orthoses, or AFOs. And this is a picture of a nighttime AFO. What it does is it gives a nice prolonged stretch of the calf muscles for the entire time that the child is wearing it, the hope being that they wear it all night. So, 8-9 hours of stretching is a lot. So this can be very effective in maintaining flexibility, and sometimes if the contracture is mild, for managing contracture. It's sometimes hard to tolerate just because nobody is used to sleeping with something stretching their ankle all night. And so sort of easing into that can be helpful. Now, sometimes we recommend serial casting, and you'll see an example of that in the picture here. What serial casting is it's a means of stretching the ankle as much as you can, putting a cast on it, allowing that cast to stretch the muscle and the tendon over a period of 3 to 7 days. Different providers cast differently. Some people leave it for a week, some people leave it for only 3 days. Then you come in, cut the cast off, stretch the ankle more, put another cast on, give it another few days, cut the cast off, stretch the ankle again until you get that flexibility back in the ankle. Some kids can undergo serial casting and it can be effective. It really just depends on the age of the child. It depends on the range of motion or the flexibility of the ankle. It also depends on the structure of the foot. So if the structure of the foot is very loose, we can sometimes actually injure the structure of the foot by casting. And so the last thing we want to do is harm a patient in any way. So sometimes if the foot is too flexible, we don't recommend casting because we don't want to put the foot at risk. So casting can be pretty effective, again, based on the child's age, as well as their range of motion or flexibility. Beyond that, if a child is really, really tight, if they're quite a bit older, if they've failed some of these other interventions, sometimes we recommend a surgical lengthening, and this is done by an orthopedic surgeon. And in the picture on the left here, you'll see there are different types of surgeries that can be done. Some of the surgeries lengthen the tendon, which is that white part of the muscle tendon unit, and some surgeries lengthen the muscle. So the surgery all the way over here on the right, this is a surgery where they just lengthen the muscle and stretch it out. And so it's a relatively easy surgery. Usually when kids have this type of surgery, they're in and out of the hospital the same day. You don't stay overnight. You're in a cast afterwards with a walking boot for about 6 weeks, and then you can come out of the cast. Now, I included botulinum toxin in this section under managed contracture, only because I think that the question comes up about whether or not to use botulinum toxins in the setting of managing contracture, specifically with serial casting and sometimes with surgery. And looking back at the research, and I looked back to see if there was anything new, most of the research actually shows that it's not effective for idiopathic toe walking. So there's no difference if you do Botox with serial casting or no Botox with serial casting. The effect is the same. And so there's a risk with botulinum toxin of causing fibrosis or scar tissue in the muscle. So for me as a provider, it's not something that I recommend for idiopathic toe walking. If there is underlying high muscle tone, it's sort of a different question altogether, because the botulinum toxin is actually treating the high muscle tone. And that's sort of a different lecture about botulinum toxin and its uses. But I wanted to bring that up because it's something that you may see if you were to look out with Dr. Google on toe walking management. So after we've managed the contracture, so we've gotten the range of motion or the flexibility of the ankle better, then we work on retraining the gait or the walking. So typical walking is with a heel strike as your initial foot contact, and then you sort of roll over your foot, your tibia or this bone here sort of advances and you roll over your foot, and that's what helps you to move forward. So when you're walking up on your toes, do, 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 you lose all of that forward momentum that a heel strike allows you when you're walking. And so we try to retrain that pattern of walking because children have learned their neural pathways in their brain and in their spinal cord that have learned to walk in this toe, 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 toe pattern. And so we have to retrain that pattern. And for little kids, it's harder for them to do this on their own. For kids who are a little bit older, for our adolescents, they can be more successful with a sort of reminder every now and then, put your heels down, put your heels down. Although I will say that some parents and kids get very frustrated by that. And so what we oftentimes will recommend is an ankle foot orthosis or an AFO during the day. And what this does is it basically forces this heel initial contact with the floor. And so we try that over a period of time to see if that can retrain that walking pattern. Gait training along with the AFO is really important with physical therapy, but also outside of physical therapy, and time. It all takes time to sort of recreate those pathways. So back to Cecilia. So her etiology, the cause of her toe walking, we thought were these sensory preferences. And she had her OT evaluation, which did indeed show some sensory preferences. And so she had a burst of occupational therapy to work on that and see if that could be improved. Once she was able to tolerate it, we did serial casting to improve her flexibility. And then we used daytime AFOs and physical therapy to retrain her gait or her walking. So does it work? What are the outcomes? What happens? You've done all of this stuff, the AFOs during the day, which, are kind of a pain in the butt. Is it actually effective? And I think the effectiveness of these interventions is really dependent on what's causing it, right? So if you have underlying high muscle tone, a lot of these kids will end up benefiting from AFOs long term. And so it may not be the case that you retrain their walking and you get them out of the AFOs and they're no longer toe walking. It may be something that we treat in an ongoing manner. Compared to a child who has idiopathic toe walking, oftentimes we are able to retrain their gait, improve their flexibility, and retrain their gait. It really depends on age. And I think the younger we see these kids and intervene, the better. Part of the reason is the more time you spend walking with that same pattern of toe, 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 the harder it is to retrain. So, I typically think of maybe seeing kids around 3 years of age if they're continuing to toe walk, so that we can prevent them from getting contracted and tight in their ankles and maybe have a better chance of retraining their walking. For kids also, the percentage of time they spend toe walking, I think, has a big impact on outcome. There are some kids who walk 100% of the time on their toes. If you get them into ankle foot orthoses, you take them off, they're on their toes immediately. For some of those kids, there may be nothing that we can do to retrain their walking. They may always walk on their toes no matter what we do, in which case that requires a lot of discussion about, well, then what do we want to do? Once we've given this a fair try, what do we want to do? Do we want to continue the daytime AFOs? Do we want to say, hey, just let them walk on their toes, they're fine, but we'll keep them stretched out at night? And so that oftentimes is a conversation. Adherence to treatment is really, really, really important. And so, when kids are off at school, if they don't have their AFOs on, oftentimes they're not paying attention. They go right back up onto their toes. And so adhering to that treatment is really, really important, especially the AFOs when we're retraining gait. And then the response to treatment oftentimes is an indicator as well. So if I find after 6 months of wearing the daytime AFOs, parents say, gosh, when we take the AFOs off, they're only, maybe 50% of the time up on their toes. That's a really good indicator that we're making some progress and that we may be successful. And so that's something that I look at as well when I think about outcome. So for Cecilia, after 6 months, we were able to get her into OT. We did her serial casting, got her flexibility back, and we got her into those daytime AFOs. And we found that, gosh, instead of 80% of the time when she's out of her AFOs, now she's at 50%. So we continue those AFOs during the day, all day, every day. And then at 12 months, parents reported that it was quite a bit less. And so we started to wean them off. And that's what we do. We say, okay, maybe you'll just wear the AFOs while you're at school, while you're not paying attention because you're learning and doing other things and playing and being a kid. And then at night, at home, on the weekends, take the AFOs off and see how you do. And so we often sort of wean off of the AFOs and see how a child does over time. So that is all for toe walking. And this sort of leads me to introduce a program that we're working on collaboratively with Reach Pediatric Rehab and Good Beginnings, because we both feel like interdisciplinary care working together, both with rehab and physical therapy, is very important in this patient population. We are working to create an interdisciplinary toe walking program. And Amy, I wanted to let you chat about that if there's anything you wanted to add.
Well, first of all, I just want to say thank you, because that was such a nice and detailed and in-depth presentation, especially from the medical side of it, which is so helpful. I think not only for us clinicians, but as for parents, because it really highlights that this is a really complex issue, and I think it's hard because it seems so straightforward, right? Well, my kid's up on my toes, they just need to put their feet down. And it's really hard to reconcile that there's so many factors that go into that. And that just like the part that you do, especially in the medical part, you have to rule out all these other issues to make sure that those things are okay. And then we've got to dive into the other parts. And then when you're talking about the idiopathic part of it, which means we just don't know why, it still means we don't know why. And so we're still we're gathering best evidence all the time, but nobody in the world right now has a single answer for this, most likely because there's not a single answer. And so it's a very complex problem that seems so obvious. And so I think it can be difficult to train your brain, whether you're the clinician or the parent or even the kid, depending if you're old enough to say, this isn't like I broke my ankle and I just have to put a cast on for 6 weeks and then maybe do some stretches afterwards. It's a much more complex problem. Yeah. And it takes a lot longer to dive deep into it. And this has been really fun to see it, again, from the outside perspective, before we didn't even get into the PT deep dive into it, right? Which is, just that, or the OT deep dive into it. So there's so much information, like there's no way we could do that all in 1 hour. So that being said, that's like, I guess the number one thing, if I'm not really going in order, but if I could share that for any parent on here, or any other clinician who doesn't already work at Good Beginnings and knows this, is that it's so complex. And this is not like a simple acute issue where you're going to go in and you're going to, someone's going to teach you stretches for 8 weeks and it's going to be fine. Like, this is really kind of a developmental issue that needs to be managed as you get bigger and grow bigger, and those muscles have to learn, and all these other body systems are changing. So just already letting yourself off the hook for that, just come in and enjoy the process. And what we're hoping with this interdisciplinary toe walking program is to make that process easier for Northern Virginia families, where we are together in the same space to get it started. And we pull from all these pieces of the puzzle to figure out what your particular child needs, because there's no one cookbook. But there is a pantry full of amazing ingredients that we can work with. And so the vision right now, we're still mapping out some of the details. We don't have an official launch date, but sooner than later is where Dr. Pham and probably me right now, but a physical therapist starts you out as your medical home to really take in this information and figure out what steps we want to try and in which order to start gaining the effects that we need for your child. And an easy to access location in Vienna, Virginia, no hospital parking garages, no, no things like that. And then you're part of this comprehensive ongoing management program that pulls in if and when you need OT, or if and when you need an ASO or other orthotic, or when it's time, when's the best time to do the physical therapy gait retraining. Some of this isn't just throw everything all at once at the same time. Brain's a complex organ, and it really needs time to organize and learn, just like anything else we learn, a new skill, a new sport, a new recipe. And so we're hoping to stay on top of it and be able to monitor the research and give you the best outcomes. So was there more about the program that I forgot about?
No, I think that's it. I think the only thing I would add to that is that my discussion today is really the medical perspective. This is my perspective as a rehab doctor. And I think the therapy perspective is very different. And so I think there's a lot more added into that when it comes to the therapy perspective, both from a physical and occupational therapy standpoint. Especially with the increasing number of kids who we're seeing who have these sensory preferences. I think the therapy portion is really integral in the management of these kids.
Well, thanks for highlighting that this isn't just the only step, but it's a really integral step, because I think it's been one that's missing around here for a while, and not by anybody's fault, but I think most kids end up at their pediatrician, right? And it's like during a well visit or something else. And your pediatrician is amazing, especially the pediatricians around here. And they have a whole list of other things that they are responsible for that nobody else is. So then they don't have time to spend all their time looking at the research for toe walking and how the protocols and whatever. It's their job to help you find the other resources. And so it can be hard because you might just get a 5-minute, like, okay, let's take a look at this. But what we really need is someone like Dr. Pham to come in and really organize the medical perspective so it can and be in charge of that and give us all that valuable information, and then work with us that she's already so well at doing, so that we can dive into the nitty gritty of our management and keep in mind her management. It's such a glorious opportunity. So sorry, I'm geeking out.
It just shows you're passionate.
Yes.
So I wanted to open the floor for any questions that people may have. So feel free to unmute yourselves and ask questions.
There's nothing in the chat so far, so we're okay there.
Great. I was just going to say, I love having conversation about things. So don't be afraid to unmute yourself and ask a question, or even comment if some of you are therapists who are on. I'd love to hear what you all think about this.
Well, I've gotten a thank you already from Marlis, one of our amazing OTs. She has to go prep for her next patient, but she said thank you. I'm sure she'll look forward to talking to you later. And again, for anybody who's not one of our GB clinicians, please jump in now. I mean, we can call Dr. Pham at any time. We can talk to her whenever we want to. So especially those of you who are parents, who've maybe had experiences trying to manage toe walking and you haven't gotten the results you needed, please go ahead and jump on. I don't know, you might have just nailed it. You might have nailed it, Kelly. You've answered all questions, or there's so much wonderful information that people just don't know where to start. So, and that's okay too. It's just a lunchtime learning. I do know there are many people who are not live on the call as well because of work conflicts. So they're going to look at the recording, and we'll invite them to email us with those questions. So right now, I guess what I was thinking is, if someone said, well, what do I do today? If this interdisciplinary clinic's not quite open today, what's the best thing I can do if I have concerns? number one, I would always recommend getting it documented on file with your pediatrician, just because they're your medical home. And so you want everybody to be involved. Like, you don't have to go make a special appointment just to say, I want you to know they're toe walking and I want to do more, but making sure you've shared those concerns with them and that you may or may not investigate outside of that pediatrician's appointment to see what would happen would be good. Even though we're not quite up for our dual clinic nature yet, Dr. Pham, people can just schedule with you right now and start as a solo patient, yes?
Yeah. Yep,
Okay, what's the
absolutely.
best way to do that?
So there are two ways you can do that. You can book an appointment on my website. Just hop on, look at the schedule and book an appointment. And once that's done, I'll call you to get more information and to chat about you and your child. And the other way to make an appointment is to call. And the phone number is 571 310 2502. You can also shoot me an email if you're a provider and you have questions, follow-up questions to this at Kelly, KELLY.Pham, PHAM at reachpediatricrehab.com. I'm always happy to chat about questions that you may have or to just troubleshoot issues that you've been having. So feel free to reach out.
Great. Oh, thanks. And then therapists are starting to drop off so they can get ready for their 1 o'clock appointments. So I think that might end up just being a good time for us to wrap up. Again,
Great.
everyone will get the recording so you can rewatch at your leisure. Dr. Pham provided us with some excellent slides, images that I think are really good to look at. And the foot is a really good thing. You know, just your video of how you did the foot was fantastic. And just to know if you are someone who's going to be seeking out an evaluation for toe walking and you do want to wait a little bit, just a smidge longer so that we can get the dual nature clinic up and running, just give us a couple more weeks and check in with Dr. Pham's office and we'll have an update for you then. Or you can always reach out to Good Beginnings and we can update you on our end as well. So any final thoughts, Kelly?
No, just thank you for having me. I appreciate the opportunity to teach and always open to questions. Thank
Absolutely.
you.
Well, thanks so much for sharing your expertise and just being a part of our team and our fellowship when it comes to this medical world of pediatrics. And we look forward to talking again soon. Thank you for
Wonderful.
participating, everyone.
Thank you. Bye.